Welcome to our podcast where we discuss behavioral paradigms that matter clinically. So, today with us we have Garima Gupta, who has a background in zoology and with a specialization in neuroscience. Welcome, Garima. So, today I wanted to ask you a question on this domain, beginning with which behavioral paradigms have the strongest clinical track record ever. So, I think that's a good starting point because, yeah, it makes the podcast really interesting. So, yeah, without further ado, you can start.
Okay, so when we talk about behavioral paradigms that really matter clinically, a few keep coming up again and again. And that's usually not because they are flashy or technically complex, it's because they capture behaviors that are both measurable and directly linked to symptoms. Fear conditioning and extinction are probably the clearest example, in my opinion. At a basic level, these tasks tells us how threat responses are learned. But more importantly, they show us how fear fails to switch off. In many anxiety related conditions, the problem isn't that fear exists. Fear is adaptive. The problem is persistence. Fear remains even when the context has changed. And that's exactly what extinction paradigms captures. This is why this task didn't just stay in the labs. They directly shaped how exposure based therapies were conceptualized, which are nowadays used to treat anxiety or depression. Clinicals, clinicians began to think of treatment not as erasing fear, but as supporting new learning that competes with older threat memories. That's a rare case where a behavioral paradigm clearly influenced clinical thinking. Another area where translation has been meaningful is social interaction tasks. As we are all aware of it, that social behavior is a complex. There's no getting around that. Mhm. But some tasks work well because they focus on simple observable elements such as approach, avoidance, time spent engaging. Right. So these measures have been useful for studying attachment, social withdrawal, and changes in social motivation, which show up across several psychiatric conditions. What matters here isn't that the task captures the full richness of social life. It doesn't. There's no task design that can wholly capture the richness of the social life. So basically, what matters is that it captures a core behavioral tendency that clinicians already recognize. And lastly, decision making tasks, especially those involving uncertainty, are another strong case. These tasks have helped us think differently about symptoms like indecision, rigidity, or altered risk perception. Instead of treating these symptoms as purely descriptive decision making paradigms, let us ask what kind of processes is breaking down? Is someone overly sensitive to negative outcomes? Are they slow to update beliefs? Do they overvalue certainty? All these questions, again, the strength here is that behavior maps onto a process clinicians already think about, even if they don't always describe it in those terms.
Right. So, I had a follow up question. So, what makes a behavioral task truly translatable? Like, I think that is what the goal is, right? That translational research, and then you are tracking behaviors. And but in the end, it is also very subjective, right? So, do you think it actually reaches its true potential of being translatable?
Okay, so when a behavioral task translates well, it usually shares a few features, such as like natural behavior, consistent meaning, and tolerance to noise. I'll explain one by one all these three features. The beginning from first, the behavior should feel natural, or at least plausible outside the experiment. Tasks that rely on extremely artificial rules often produce clean data, but fragile interpretation. By contrast, simple choices, approach versus avoid, wait versus act, tend to travel better across species and settings. And second, the behavior should mean roughly the same thing wherever it's measured. For example, if a task reflects stress in animal but something entirely different in humans, translation becomes shaky very quickly. And third, the task has to tolerate variability. Like real world behavior is noisy. We are all aware of it. People have differently across days, context, and emotional state. Sorry, what I mean is people behave differently across days, context, and emotional states. So tasks that collapse once conditions become less controlled rarely survive clinical translation. So, in my opinion, the tasks which are very near to the natural behavior or and now near to this real life experience are the only ones that gets translated into real life settings.
Right. Okay. So, coming to another question. So, where have widely used tasks failed to translate? Can you talk about those, like those studies in detail?
Okay, so there are many failure points. Few of them, which are, in my opinion, are very important to discuss. As one common failure point is oversimplification. Some tasks are excellent at isolating a mechanism, but they remove so much context that the behavior no longer resembles how symptoms appear in daily life. Another issue is over reliance on single readouts. Reaction time or accuracy alone often can't capture complex states like anxiety or motivation, since they are influenced by many other factors. There have also been cases where tasks became popular before their limitations were fully understood. So, when results fail to replicate across population or labs, the clinical value dropped sharply. The key lesson here is caution. Popularity doesn't equal validity, and convenience doesn't equal relevance.
I truly agree with you, Garima. So, how can computational modeling, as an alternative, enhance clinical usefulness, do you think?
Okay. In my opinion, computational model helps us look beneath surface behavior. For example, instead of asking who performed better or worse, computational modeling helps us to ask how decisions are being made. Parameters like learning rate or sensitivity to outcomes can reveal meaningful differences between individuals, even when their overall performance looks similar. Clinically, that matters. Now, two people might describe similar symptoms but arrive there through very different processes. Understanding the difference is key for personalized approaches. We cannot go with one fit all approach. At the same time, models need careful interpretation. They are tools actually. They are not answers. So we should use computational modeling to because they help us ask better questions, but not as a replace, not to replace clinical judgment. They are just tools, not answers.
Right. That brings us to the end of the episode. Thank you, Garima, for joining us, and thank you, listeners, for listening to us.